Hello everyone, so great to have such a weather here. SBRT is well established in the treatment of stage 1 non-small cell lung cancer. These are the regimens that we use in Gdańsk, based very much on the work of Professor Suresh Senan in the Netherlands, who pioneered the use of SBRT in early non-small cell lung cancer. We typically give 3 fractions or recently 1 fraction for lesions that are far from the chest wall. Close to the chest wall, we still go with 50 Grays, 55 Grays in 5 fractions. And for the central lesions, ultracentral lesions, we typically hypofractionate with 15 or 20 fractions. For central lesions that are slightly more distance from the mediastinal structures, we use the scheme that was elaborated with the ERTC study 60 Grays in 8 fractions. It's very important to emphasize the technique and the quality control of the radiation procedures, which is always respiratory motion control with for DCT planning and deep inspiration, breath hold, and obviously image-guided delivery, which is a must. This is an example of a patient that was treated with 54 Grays in 3 fractions. Now we would consider 30 Grays 1 fraction for such a patient, 55 Grays in 5 fractions for the lesions that are abutting the chest wall, and 60 Grays in 8 fractions for the ultracentral tumors. Now this is the graph that is already over 10 years old, but very nicely depicts the problems that we have. We have, that is again from the group of Professor Suresh Senan, excellent relapse-free survival, regional relapse-free survival from the series of over 600 patients, slightly lower metastasis-free survival, but overall survival, which is much worse, and that is due to comorbidities, mainly cardiovascular issues. Here the median overall survival is 3.5 years, and we checked that in our series from Gdańsk. It's exactly the same, 3.5 years. This is because most of our patients are medically inoperable patients, that they are not candidates for surgery because of comorbidities, poor pulmonary fraction. Still in Gdańsk, most of our patients who are operable will go to surgery, and all these patients who don't elect to be treated with surgery or are medically inoperable will go to SBRT. For central tumors, classical definition was 20 millimeters from mediastinal structures. In the LungTech ERTC study, we have tried to work up the dose of 60 Grays in 8 fractions for such lesions, and we elaborated dose constraints very nicely with the ERTC group, which help us still today when we decide on the treatment possibility to deliver the treatment within these constraints. The study was closed prematurely because of 2 deaths. You can see here grade 5 toxicities for the tumors that are located on the right side in red. However, the local progression-free survival in the primary analysis that was done a couple of years after that shows us excellent progression-free survival. So this is the trade-off between ultracentral lesions up to 10 millimeters and a probability of grade 5 toxicities, usually linked to hemorrhage. The safety and efficacy of SBRT for central lesions was also assessed in the United States in this study, RTOG 0813, with the final conclusions that 50 to 55 Grays is safe in 5 fractions, and our American colleagues use 50 Grays in 5 fractions in this scenario. For operable stage 1 non-small cell lung cancer, The debate is still ongoing. We had 3 clinical trials, phase 3 trials, trying to address these questions. Unfortunately, all 3 were close to poor accrual. Over 10 years ago, the primary analysis from 2 of these trials show comparable results of SBRT and surgery, adding to the value of the discussion. Right now, we only have propensity score propensity score studies, such as this one from the Netherlands, showing that SBRT in operable patients can also be linked with excellent local control exceeding 80%, regional control, and distant control. This is a Kaplan-Meier curve from such a study. There are studies that are suggesting the benefit of surgery, studies that are suggesting the benefit of radiation in the operable group with propensity score matching. But these are studies with limitations of retrospective analysis. For example, meta-analysis of these studies is showing us that studies with SBRT are typically done in older patients, surgery, younger patients. When you match these patients, of course, you can get some conclusions, but this is still matching. This is not still randomization. From these studies, you can also see that the local control with surgery and radiation is similar with something like 80%. So probably we are just debating about different groups of patients. There are 2 ongoing studies that are addressing the issue of SBRT versus surgery. The one, Stablemate, that is designed to ask this question in a high-risk operable stage 1 non-small cell lung cancer, is run by Bob Tieberman in the US with sublobar resection compared to SBRT. This is a 218 patients trial. Hopefully this will help us answer the question whether SBRT could substitute for surgery in high-risk patients, something that we are already doing, in fact, in our in our MDT discussions daily, as, for example, our last one with Witold, and we debated on a couple of patients with high-risk features. And then, most importantly, VALOR study, VA study in the United States, which I heard accrued over 500 patients out of 670, which is a randomized study for surgery of SBRT, and then eventually adjuvant therapies according to standard of care. Hopefully this study will answer the most important question for the moment, whether SBRT can be given as an alternative to surgery in operable patients. In stage 2, 3 non-small cell lung cancer, conventional chemoradiation is still the standard of care, with the problem of mostly distant failures, as about 20% of these patients will relapse in the primary, 10% in the mediastinum, which is quite interesting to note that the risk of mediastinal relapse is lower in these patients, and still the majority may relapse distantly. Which out of the studies that preceded Pacific, we know that the protocol compliance and the quality of radiotherapy is extremely important. So daily cone beam imaging, extremely important. Breath motion control, extremely important. Proper PET staging is extremely important. And once you have patients without any violations from the quality control protocol, your probability of long-term overall survival is higher than probability of survival of these patients with deviations from the protocol. And then Pacific, trying to address the benefit of systemic therapy in patients treated with concurrent chemoradiation, with long-term results of over 40% 5-year survival, which is really great as compared to historical controls. So optimization of local control as of today is probably coming from, first of all, the quality of radiation planning, delivery, and supportive care. The target volume adaptation during radiotherapy is maybe a question for the future. The higher dose to the primary tumor, such as an SBRT boost to the primary tumor, there are some trials addressing the issue of about 20% local relapse rates. This is important, but probably will not change the overall landscape. And we are also thinking about de-escalation of radiation in some patients who have certain biological features of high sensitivity to systemic agents. And of course, keeping the low dose to the organs at risk is extremely important. Over the last 10 years, we also learned about the heart doses, substructures to the heart, lungs and esophagus, and we are doing our tricks to minimize these doses. Now, from the systemic control in stage 2, stage 3 inoperable non-small cell lung cancer, there has been a debate how we can improve upon PACIFIC results. And the 3 different groups of clinical trials will address the issue of improved consolidation beyond durvalumab in the PACIFIC study, concurrent and consolidation treatment with immunotherapy, which is largely disappointing and probably not going forward, but an intriguing way to elaborate better systemic treatment for these patients is perhaps with neoadjuvant and consolidation, a little bit similar to surgical patients. So I'll put here that, on this graph that improved consolidation is a proven concept. There are several promising targets, which in my opinion, PACIFIC 9 is perhaps the closest to be read out in the very near future with monalizumab and oleclumab, 2 different checkpoint inhibitors compared to durvalumab consolidation. However, we have seen multiple failures in this field with other checkpoints that didn't add to PACIFIC in this scenario. Concurrent and consolidation is a loser here, unfortunately. We've been watching very rapid and perhaps not well thought over jump into studies with concurrent immunotherapy and consolidation immunotherapy rather than consolidation only. The failures are probably due to 2 reasons. First of all, we may be shooting at our own lymphocytes during concurrent treatment, so probably there is no benefit of activated immune response and ongoing radiotherapy with lymphocytes being most sensitive cells in the human body. Now, who knows? But then we have another issue of rapidly shrinking tumor volumes during chemo, radiotherapy, and immunotherapy, and the question of organs at risk, pulmonary, more toxicities like pneumonitis, that is quite obvious if you analyze those trials. With neoadjuvant and consolidation, this is promising, but we have only early phase 2 data. Early systemic treatment in high-risk disease may have some benefits of addressing systemic disease, but also intact tumor microenvironment is important for immunotherapy, and we do know about it from neoadjuvant pre-surgical trials. No phase 3 data reported as yet, but stay tuned. This is the avenue that hopefully will bring some novelty. The question is whether we can de-escalate radiation in some of these patients, how and why. So with that, I'll stop here and say that I'm so happy to, together with Witold, have this meeting with Gdańsk, where we work hard to benefit our patients and innovation, including early lung cancer detection, and with many hopes that it will also serve our Ukrainian colleagues from the country that is close to the situation, as we try to train them also in our institution as a part of our curriculum. Not only treat patients from Ukraine, but also train the physicians, as we think it's moral obligation for us. Thank you very much for your attention.